Thank you, Brian, and thank you for the excellent talk and the excellent oration. And
My pleasure.
Hope to see you back in Calcutta sometime next year.
I hope so too. Thank you, and greetings to everybody who's online that I haven't been able to see. So thank you for the opportunity to speak with you. Thank you.
Thank you.
So we move on to our next topic, that is management of renal hyperparathyroidism. Again, something which is quite common, which we see in our practice. And to deliver this lecture, we have our international faculty, Dr. Sankoorikal, and who is a consultant endocrinologist at the John Hunter Hospital, University of Newcastle. He's also faculty at the University of Newcastle, and he's currently a staff specialist at the Department of Endocrinology at the John Hunter Hospital, and he is also faculty at the University of Newcastle. His area of interest is basically diabetes and osteoporosis, with osteoporosis and metabolic bone condition. So welcome, Chris, and hope we have an interactive session. It's really nice for you from your part that you have taken your time out on a Sunday, to really participate as a faculty. Thank you.
Oh, well, thank you so much for that kind introduction, Dr. Sanyal. Well, greetings to everyone from Newcastle. First of all, let me thank the committee, the Charles S. Memorial Committee, for this kind invite, and it's a real pleasure to be part of this webinar. Now, I'll try to share my screen. Just bear with me if I start it up. Oops. Now,
yeah, it's
how is it?
Yeah, you can go for, yeah, fine, excellent.
Yeah, good. And I hope the audio is also.
Yeah, audio is fine.
All right.
Over to you.
Thank you. So without further ado, I'll just get into the topic. I've just modified the title just a little bit, because as I was preparing for the talk, I thought rather than just focusing just on renal hyperpara for 20 minutes, I thought it's probably better to give a bit of an overview of CKD Embedding. So what is CKD Embedding? Now, this is a term coined by KDIGO, and if anyone of you don't know what KDIGO is, it's the International Working Group for Kidney Disease for Improving the Global Outcomes. So they coined the term CKD Embedding, and it stands for Chronic Kidney Disease Mineral Bone Disorder. And basically, it's a term to describe these three categories of conditions. So starting off with biochemical abnormalities, the bone disease, and the extraskeletal calcifications. So we'll be touching on these in the next few minutes. So first of all, with the biochemical abnormalities, starting with changes in PTH, FGF23, calcium, phosphate, and 1,25-dihydroxyvitamin D, which I'll from now on call as activated vitamin D. And then the bone disease part, which includes the high bone turnover disease, the adynamic bone disease, osteomalacia, and also osteoporosis. And then also to quickly touch on extraskeletal calcifications, which involves vascular and valvular calcifications and also soft tissue calcifications. So I guess the first question we always ask, why should we care? Is it really important? And the answer is clearly yes. These biochemical adaptations, it starts off at adaptations, but soon it becomes a maladaptation, leads to, first of all, bone disease and further fractures. And also on the other side, it can also result in extraskeletal calcifications, leading on to cardiovascular death. So these maladaptive changes are important to understand and to be managed. Now, let's start from the beginning, how the story starts for a CKD patient. Here on your x-axis, you've got the GFR, and on the y-axis, you've got the different analytes. So the 4 analytes I would like to discuss with this graph is the fibroblast growth factor F23, which is otherwise called the FGF23, the 1,25-dioxyvitamin D, otherwise the activated vitamin D, the PTH, and the phosphate. So as the journey starts for Is Ckd patients, we see that most of these parameters are within the normal range. And the first change to occur, and that happens when the GFR is around 75 mils, is the slight rise of FGF23. And then following that, and that's the red line, and following that, you see a slight reduction of the activated vitamin D. And then as the GFR continues to drop, you start to see a rise in the PTH. Remember the phosphate level almost maintained very well till the eGFR drops to around 30. Once the eGFR drops to 30, the phosphate levels can slowly start to rise. The FGF23 rises exponentially, and the same with the PTH. And once they get into the dialysis range, these levels are at the extremes. Why does it happen? Now, it's all to do with phosphate. So phosphate is the main target for these 3 agents. So the FGF23, PTH, and activated vitamin D, they are all working in concert to control the phosphate. So I think this is a nice diagram which shows you the relationship and how phosphate is influenced by these 3 factors. So first of all, FGF23, here the solid line indicates an increase or a stimulation, whereas the dotted line indicates a reduction or suppression. FGF23 helps to reduce the phosphate levels. Same with PTH, it helps to reduce the phosphate levels through phosphaturia. The reverse is also true. A high phosphate can stimulate FGF23 and a high phosphate can stimulate PTH, so it works both ways. On the other hand, the activated vitamin D, if the level is high, it actually stimulates phosphate, whereas high phosphate can have a negative influence on 1,25-dioxyvitamin D level. So now we can see why these changes occur in the initial phase. So the rise in the FGF23 and the PTH is actually to control the phosphate level in its normal range. And probably the same with the reduction in vitamin D level, activated vitamin D level actually helps to keep the phosphate in the normal range. Now, the relationship between all these factors are a little bit more complex than what I initially showed. In fact, there are some direct relationship between these factors as well. The FGF23 has an inhibitory effect on PTH, whereas PTH has got an excitatory effect on FGF23. 1,25-hydroxyvitamin D again has a stimulatory effect on FGF23 and the reverse. And what's also important is, again, activated vitamin D has a inhibitory effect on PTH, whereas a high PTH can increase the 1,25-hydroxyvitamin D. So I think this relationship is key when it comes to understanding the pathophysiology, and it does have some implications on treatment as well. The result of that initial adaptation followed by maladaptation is that there is a significant rise in phosphate eventually as the patients progresses into their disease. There's a reduction in activated vitamin D, and this results in low calcium. And this in turn stimulates PTH from the parathyroid gland. And the high PTH, or otherwise called hyperparathyroidism, which in this case it will be secondary hyperparathyroidism, in turn causes some systemic toxicity, results to bone disease, which we will touch on later. The high phosphate also has a stimulatory effect on the FGF23 as well. Now, this is one of the key players in the pathophysiology of bone disease, but that's not the only player. In recent years, we also understand that Wnt signaling is also a major player in this pathophysiology. And I'll spend a couple of minutes quickly discussing wind signaling, because I think it's important to understand the disease, and also some of the emerging treatment involves this wind signaling as well. So I'll first of all draw your attention to the left side of your screen, where you have the activated form of wind signaling. So the key protein in this wind signaling is beta-catenin. So beta-catenin is a protein that enters into the nucleus, and it facilitates gene transcription as well as cell proliferation, in this case, which is the osteoblast, it causes osteoblast activation and thereby bone formation. So there is three key components. One is the cell receptor complex. Then we have what's called the destroyer complex, and then we have the beta-catenin itself. So what happens is, the first step in terms of activation of the wind signaling pathway is the attachment of wind on the receptor, the LRP5 and 6 receptor. When that happens, it recruits this protein called the fristle protein, and the combination of fristle protein and DISH and the wind and LRP together attracts this destroyer complex, and it holds in check. So what happens there is the destroyer complex is now attached to the receptor, and therefore it does not act on the beta-catenin to destroy it or to disintegrate the beta-catenin. So then we've got plenty of beta-catenin available. Beta-catenin enters the cell and it does its job, which is gene transcription and increase of the activity of osteoblast. Now, on the middle column and right column, these two proteins, one is the DKK1 and sclerostin. These are the two agents which acts as a counter check to the system. So first of all, with DKK, it binds to the LRP5 and 6 receptor, which then result in internalization of this receptor. And one of the other receptor that helps this process is called the cremin. So as these receptors are internalized, it does not get expressed in the cell surface, so the wind does not have a site to attach. So when wind is not attached, the receptor complex is not active, then the destroyer complex gets the free hand in destroying the beta-catenin, and therefore there's not enough beta-catenin, there is no gene transcription, the osteoblast is not active. Very almost similar in this case of sclerostin, where the sclerostin blocks the LRP5 and 6 receptor, stops wind from activating the signal pathway. Again, the destroyer complex get a free hand, it destroys the beta-catenin, no gene transcription, no activation of osteoblast. So in other words, the DKK1 and sclerostin causes reduced bone formation. And in the setting of CKD5 and 5D, we know that there is a significant rise in sclerostin, almost 2 to 3 times. DKK1 is not that high, but still slightly elevated. On the flip side, this may act as a protective process as well, especially in the extraskeletal tissue, where increased sclerostin might be protective because, again, if you think about it, sclerostin stops bone formation. Now that's important because as we see sclerostin, anti-sclerostin agents are going to be used more and more for the treatment of metabolic bone disease. And now with this information, you can understand how it actually works. Now, when it comes to management of the biochemical abnormalities, again, coming back to phosphate, which is the main villain, the goal is to keep the phosphate in the normal range. Initially, your own biochemistry tries to keep it in the normal range, but after a while, it's overwhelmed by the rise in phosphate. So that's where you'll need to intervene. So it starts off with dietary control of phosphate. And there is some evidence, this is probably good news for vegetarians, the vegetable source of phosphate is better than the meat source, and it tends to cause less hyperphosphatemia after ingestion of that phosphate. After that comes phosphate lowering treatments. We've moved away from the word phosphate binders because there's newer products which are going to come, which works slightly different to just binding. So phosphate lowering treatment will be the next step and will be indicated when there is persistent hyperphosphatemia, which is refractory to dietary intervention. And when you choose a phosphate lowering treatment, while calcium-based treatment is a lot more cheaper, there is some evidence that it increases cardiovascular morbidity and mortality. And if there is a choice, better off using the newer agents with this lanthanum and sevelamer, but however, cost will be a factor. Those who are on dialysis, another way of getting rid of phosphate is by through dialysis. So you can modify the dialysate to excrete the extra phosphate, but you can only do it like once every 2 to 3 days. The other biochemical abnormality that we need to target is the hyperparathyroidism and how we balance the calcium. The goal is actually to keep the PTH not in the normal range, but somewhere between 2 to 9 times the upper limit of normal. The reason for that is not all the PTH that we measure is active PTH, and most of the labs here in Australia and all over the world use the second generation PTH assay, or otherwise called the intact PTH assay. And it does detect some what's called C-terminal fragments of the PTH. So the PTH level when measured may look high, but in the actual active PTH may not be that high. So we can't just bring the PTH to the normal range. We just allow for that inaccuracy and try to keep it somewhere between 2 to 9 times the upper limit of normal. Secondly, it's also important to prevent hypercalcemia and hypocalcemia. So to achieve that, what we use is calcitriol or activated vitamin D, and then vitamin D or the analogs, all calcium mimetics, but mainly when the secondary hyperparathyroidism is quite severe. How do we know whether the secondary hyperparathyroidism is severe? Well, you might be able to get some information from serum alkaline phosphatase. Obviously, if the patient has abnormal liver function tests, it becomes hard to interpret. And this is where you can use, if it's available, bone-specific alkaline phosphatase, as well as P1NP, which are byproducts of bone formation. Again, those who are on dialysis, you can modify the dialysate for, and its calcium concentration so that you can bring the calcium down. In severe cases of hyperparathyroidism, you'll need to undergo parathyroid surgery. Now, the main goal of treatment is to avoid overtreatment with calcitriol vitamin D level and to avoid particularly increase in serum calcium or hypercalcemia. Just moving on to bone disease. Again, the question is, why do we care? The reason why we care is because the risk of fracture is reported to be about 4 to 14 times higher in patients with end-stage kidney disease relative to individuals without kidney disease. So that's really high. The fracture incidence in end-stage patients is quite similar to individuals about 10 to 15 years older than them in the general population. So that's the amount of risk that these patients are facing. The high rate of vertebral fractures in hemodialysis patients, and this is patients who don't necessarily have osteoporosis, is almost comparable to an osteoporotic control population. So the increased risk of fracture actually extends to non-dialysis CKD patients as well. And it confers about 1 to 3 times the risk of fracture compared to non-CKD population. So CKD populations, by default, for the same bone density, they are at higher risk of fractures. And what are the outcomes after an admission? So this is comparing the type of admissions these patients have had. So you're comparing non-fracture admissions versus fracture admissions. So after a non-fracture admissions, you're less likely to go to a nursing home. And by nursing home, you mean It's a facility or residential facility where patients need full-time care, nursing care. So they need to be transferred into a nursing home more often if you have a fracture, and there's a huge difference between the two, than a non-fracture admission. And when it comes to death, again, you're more likely to die after a fracture admission versus a non-fracture admission. So the 12-month mortality rate of CKD patients after the first fracture is really high at 41%, which is almost twice that of the general population. And a lot of this information is local from Sydney. So when you try to think about bone disease, this is what you should try to visualize in your mind. So there's three key characteristics. One is the turnover, which is bone turnover, the bone mineralization, and the bone volume. And so this is called the Tmv classification, which is a popular way, not a popular way of explaining this. So first of all, when you look at bone turnover, at one end, you've got adynamic bone disease, where there is no bone turnover or very low bone turnover. And at the other end, you have the high bone turnover disease. I have also put osteomalacia there because osteomalacia is a low bone turnover disease, but the mineralization may not be normal. It's actually abnormal. So in osteomalacia, it's hardly any mineralization, and the bone density can be low. And then you can get a mixed pattern of all this as well. Now, when you assess for bone disease, these are the things that you consider based on that previous graph. So the assessment of bone turnover, and we usually use PTH. PTH is still the best, despite its shortfalls, it's still the best predictor. You can, if you can rely on the alkaline phosphatase level, that will be a good indicator. And if you have access to bone-specific alkaline phosphatase and PM1NP, these would indicate whether the patient is in a high bone turnover state or not. I put TRAP5V in brackets because, again, it's not a commercially available assay, from what I can understand anywhere. But if you can get it, it shows what your bone resorption status is. Secondly, bone density. Now, previously, KDIGO did not endorse bone density because apparently they thought, or based on evidence at that time, they didn't think it predicts fracture. But now, as per the latest guideline, they do endorse the use of DEXA scan in this setting, where if the bone density is actually low, they are at much higher risk of fracture. Now, to understand the disease, the gold standard is still bone biopsy. However, bone biopsy is not an easy test. Doing the biopsy is somewhat cumbersome. Expertise to read bone biopsy specimen is also not easily accessible. And this is what you're trying to understand from either biochemistry or the bone biopsy. So in high bone turnover disease, which usually will be characterized by very high PTH, almost like 10 to 30 times the upper limit of normal, high alkaline phosphatase level, and bone-specific alkaline phosphatase and PM1NP. And the bone density can be variable. It could be low, it could be normal, it could be even slightly high. Depends whether they've got concomitant osteoporosis as well. And on the bone biopsy, that's the normal bone biopsy, where you can see a thin layer of osteoid, and there's some new bone being formed by osteoblasts. Whereas on your right side here, you can see the bone looks a little bit thicker, but the quality is not the same as normal bone. And the cells, particularly the osteoclast cells, are a bit larger. There's more of them. So basically, it's like an angry looking bone with lots of osteoclasts, lots of osteoblasts, laying bone in a slightly hepatocyte type of way. And when this process happens locally, that's when you get what you might have heard about this brown tumors. And this is a X-ray of brown tumors where it gives you like a partly cystic appearance, and it compromises the strength of the bone, and people can fracture from it. And you can get these brown tumors almost anywhere in the skeleton. Coming to adynamic bone, which is just the reverse, where the PTH is low, the alkaline phosphatase tend to be low, the bone density is usually low or can be normal. And in bone biopsy, this is again what you see. So here's the normal subject where there's a lot of activity in the periosteum. There is new bone formation. There's multiple osteoblasts and osteoclast cells, whereas on your left side, you see almost a bland looking bone structure with no activity at all. So that's the characteristic of adynamic bone. And finally, osteomalacia. So this is a problem with mineralization of the bone. You would have heard about osteomalacia and severe vitamin D deficiency, and it's almost the same, but not exactly the same. So osteomalacia, it's slightly less common these days because one of the key causative factors for osteomalacia was aluminium used in dialysis patients, which is not that commonly used these days, I think. So you see a slightly high PTH, a slightly higher alkaline phosphatase and bone turnover markers, and the bone density can be variable. Bone biopsy will show abundant osteoids. So here this line in orange in the normal subject is very different to what you see on the right side, where there is very thick osteoid. So this is like soft bone with no mineralization, which is the characteristic of osteomalacia. So these are the key things we are trying to differentiate. So once we get an understanding, either through biochemistry or through bone biopsy, of whether it's high bone turnover, low bone turnover, osteomalacia, that's when we think about treatment. So the treatment is basically modulation of bone turnover. So in high bone turnover disease, you try to suppress the bone turnover. That could be by suppression of the severe hyperparathyroidism. And once that's achieved, if the bone density is low, you could carefully use bisphosphonates or denosumab. When it comes to low bone turnover disease, it's a bit harder. Again, if the PTH is suppressed, you may wish to just relax that control a little bit just to kickstart some bone turnover. There's some very, very slim evidence behind the use of anabolic agents. So teriparatide, particularly if the PTH is not high, and usually it's reserved if they've got fractures in the low bone turnover setting. So teriparatide is an option, but it's an expensive option. Now, romosozumab is the new anti-sclerostin agent, and I've shown you how anti-sclerostin works. It's an anabolic agent because it stimulates the Wnt signaling pathway. We are very keenly following how romosozumab works in CKD population. We've got evidence that it works really well in CKD 1 to 3, whereas with 4 and 5, I think the data is just emerging. If osteomalacia is the cause, well, again, if aluminium is being used, we should be stopping it, and you should very carefully supplement activated vitamin D to address the vitamin D deficiency, which also can cause osteomalacia. Now, how are we going with time? Am I going overboard? I'm just trying to see.
How much time do you have?
I've just got 4 or 5 slides.
Yeah, you can go ahead, please. Yeah,
okay.
yeah.
All right. Can you see the slide? Can you see the slide?
Yeah.
Okay. All right. So I'll just quickly go through a case and then we'll conclude. So this is a patient I saw in 2019, and she was referred to me for management of her osteoporosis, which was diagnosed on a DEXA scan. There was no history of fractures. The background history was of CKD5D from diabetic nephropathy. She had calciphylaxis in 2015, following which her calcitriol was ceased completely, and she was started on cinacalcet, which is a calcium mimetic. And this was the biochemistry when I first saw her. So the calcium was at the lower end of normal, the phosphate was in the normal range, the PTH, the intact PTH, was slightly elevated, the P1NP was elevated, and the bone specific alkaline phosphatase was also slightly elevated. Again, the alkaline phosphatase was elevated, and the rest of the liver function tests were normal, so we could easily interpret that alkaline phosphatase. But what was key was the 125 dihydroxyvitamin D was undetectably low. The 25 hydroxyvitamin D was also on the lower side. And this was DEXA scan, which compared to 2015, had shown an 8.3% drop in the lumbar spine, a 13% drop in the left total hip, and that left her with osteoporosis along the left neck of femur and osteopenia along the left total hip. Interesting, the lumbar spine was normal, and when you look at the x-rays, you see why Even though the bones are thin, there's a lot of vascular calcification along the abdominal aorta, which will spuriously raise DEXA measurements along the lumbar spine. And that's all due to vascular calcification. So here we've got this lady who's got undetectable 125 dihydroxy vitamin D level, a slightly raised PTH and alkaline phosphatase, and osteoporotic bone density values. So the question is, what's the diagnosis? So based on the fact that the calcitriol was seized and she had no 125 dihydroxy vitamin D at all, we thought there could be a component of osteomalacia, and clearly her bone densities are very low, so she's got osteoporosis as well. So the treatment was initially directed at the osteomalacia, so we treat with calcitriol, started at very low dose, keep a close eye on the serum calcium, make sure that it does not go above the reference range. If possible, try to keep it in the low normal to mid normal range. Make sure that the phosphate, so when you start calcitriol, what happens is the phosphate can go up, so we need to keep an eye on the phosphate as well. And also keep an eye on the 125 dihydroxy vitamin D level. Again, remember the feedback systems there. If you treat with calcitriol, it can, if you overuse it, it can increase phosphate level, which is detrimental. And we try not to suppress the PTH fully and try to keep it at a slightly high level. So this is her last year when I saw her, about a year later. So calcium had gone up from 2.2 to 2.4. The phosphate had gone up a little bit, but still in the normal range. The PTH has risen slightly, but the alkaline phosphatase has dropped to 130, and the 125 dihydroxy vitamin D level is now detectable at 33, well below the normal range, but still detectable. And the 125 hydroxy vitamin D level was also slightly in the low normal range. The bone turnover markers had reduced to some extent. So DEXA scan, the lumbar spine was stable. There was still a drop of 3% along the left total hip when we did the DEXA again, and it showed osteoporosis of both hips. And I think the main reason for that, she had been less ambulant during this time, so that also matters. So at that time, we decided, okay, now it's time, we've treated the osteomalacia, let's treat the osteoporosis. So she was started with risedronate, which is usually a once a week tablet, but in CKD population, we give a lower dose, which is given fortnightly, and we're eagerly awaiting the next DEXA scan in 2021. Finally, vascular calcification is also a main issue. The reason is the imbalance between the promoter of calcification and the inhibitors of calcification. The increased calcium phosphate product and the raised PTH are some of the major players. And these products, the inhibitors of calcification like ketuin, active matrix glyprotein, and pyrophosphate, all of those promotes vascular calcification. Again, when it comes to assessment, what we recommend is an abdominal X-ray at the minimum, if required a CT scan, and an echocardiogram to see for any vascular calcifications. The treatment goals, again, avoiding hypercalcemia, minimize hyperphosphatemia, and control the hyperparathyroidism at the levels that we discussed before. So quickly on the take-home points, there are multiple biochemical, skeletal, and vascular adaptive and maladaptive changes that occurs in patients with CKD as they progress through the different stages of the condition. These maladaptive changes can result to fractures, cardiovascular disease, and increased mortality. Our treatment should be, over-treatment should be avoided, while management of the biochemical abnormalities so that the normal protective adaptation process is allowed to continue. While assessing for bone disease, assessment of the bone turnover, bone volume, of density and mineralization should be taken into account to tailor treatment. And that's it.
Nice.